So today I have the unique privilege of sitting down with Major Sonya Vargo, who is a trauma critical care nurse and an instructor at the Army Trauma Training Center, as well as Colonel Mark Buzzelli, who is a trauma surgeon and the program's director. They both give great detail as to why it's so critical that our medical professionals complete this training just prior to being deployed. And they both give great insight into their own deployments and experience, which include as recently as Colonel Buzzelli's, which took place this past August in Afghanistan during that heart-wrenching troop withdrawal. On a side note, the views expressed are those of the author and do not reflect the official policy or position of the U.S. Army, Department of Defense, or the U.S. government. So, let's do it.
Too many days in the darkness without a glimpse of the light. Running tired and broken and scared, but I swear I'll never give up the fight. I see you broken and beat, head pulled down over your eyes. Every part of you wants to surrender, darling. You were meant to survive with every star.
Alrighty, so thanks for coming on today, Colonel and Major. I definitely appreciate it. I am so stoked and excited to hear all about the Army Trauma Training Center and also, your backgrounds as well. If you guys don't mind just basically taking the floor and just giving us some insight into like what you guys do specifically, and then also what the trauma center is designed around serving.
Me to start?
Yeah, go ahead, sir. Yeah.
So, hello. Yeah, Daniel, we're so glad to be here and thankful for the opportunity. My name is Colonel Mark Buzzelli. I am a trauma surgeon, an active duty member of the U.S. Army, and currently the director of the Army Trauma Training Center, which many folks might not know, but it's been located here at the University of Miami School of Medicine and the Ryder Trauma Center for 20 years now.
I did read that. I read that it's 20 years, I believe, this past year, and it started September 10th, 2001.
Correct. That is.
I thought that was like the oddest timing for that, by the way.
Yeah. So there was some history to having these military-civilian partnerships at trauma centers that predates our existence here at Miami, but the agreement with the University of Miami and Ryder Trauma Center was apparently the original agreement was signed on September 10th, 2001. The significance of the training center became much greater, of course, the very next day when we actively engaged in the global war on terrorism and have since for the past 20 years. But I believe the actual first attendees were this month, were January of 2002. So we are truly at the 20-year anniversary mark of its first class. Yes.
Okay. Yeah, there's probably a lot of changes since then, because you guys were basically setting up pre-war almost, right? That was the intention, and then all of a sudden the next day,
correct,
things kind of changed the entire itinerary, right?
Yeah, I mean, one of the mantras I think within the military is you train to fight, and we just so happened, like he said, it just got signed, and all of a sudden it became real, and became a real big deal, and it still has been, as you see in the news, right? That we're all over the world, constantly needing that military support, but also that medical support as well.
Yeah, I feel like people don't really realize that. They just see the guns and the people breaking in the doors and so, but...
Oh, 100%. Even most recently, after the Afghanistan war piece, right, that was on the news, we have some of our counterparts that we work with that even said, why is the Army still training here at Ryder Trauma Center? The Afghan war is over. And a lot of them are younger individuals, right? Like that are probably med students or nursing students, right? Not fully understanding that we have a presence all around the world, and that doesn't stop training. You continue to train just because, right? Like we're not in an active engagement, maybe to some people. But obviously, we can't disclose everywhere that we are, but that medical training, it's like riding a bike. If you don't practice it, right, you're gonna get a little weak on your skills, and that's what we do, is make sure that the best of the best are training, And that's why our men and women fight, is because they know we've got the best medical training, and that's what we provide, and to bring them home safely.
Yeah, because from a little bit of my research, you guys kind of specialize in training those just about to deploy.
Correct. So while the original idea, again, pre-September 11th, was just kind of more of a maintenance training, it was kind of born out of the experience of the Gulf War of the early 90s that we fortunately, because that war was so brief, didn't really have many casualties, but there was, at least amongst some of the medical leaders of that time, some acknowledgement that maybe we weren't quite as ready on the medical side to deal with major traumas. And so this idea of embedding military teams at very busy civilian trauma centers came to life. And that's eventually, by the time they got around to partnering with the University of Miami. But the thought is, if you're not continuously practicing as really a trauma team, you're not going to be as prepared as you maybe need to be. So the notion was there from the start that you gotta, like we've said, train like you fight, and be prepared to take care of military style casualties, which not too many trauma centers see on a regular day basis.
Yeah, for sure. Because those that you're training to, are they the ones that are on the ground too and doing, in combat style life-saving skills, or are they the ones where, the medevac brings them back to, so they can, perform surgeries, and so are they in the field during that, or a combination?
That's actually a really great question. One, we do train active duty and reserve folks, and we also have some people from our special forces, like special operations, I should say. That community also comes and trains with us, just to, again, brush up on their skills. But it's both. We've got FSTs, which are forward surgical teams, and forward resuscitative teams, right? They jump out of airplanes, with their equipment, and they're able to set up within a 12-hour time frame. Usually they're able to take patients within an hour or two of tailgate medicine. And then they have surgical capability. And I think that's what makes us so special, because there's really not a lot of that capability around the world, is that we can really participate actively with the warfighter that's moving forward. We can move forward with them and then keep them within that golden hour that you've probably heard of, life, limb, eyesight. And sometimes you have to jump out of airplanes. Sometimes you got to be brought in, to buy like a C-130. Sometimes it's got to be by ground, and you'll have maybe a fixed facility. And sometimes they're doing it surgeries out of a blown out building. When you think about what we can do, it's quite amazing.
Yeah, I feel like you guys are the difference between why we're not, in the Civil War era, just, all right, you got shot in the arm, cut it off type of thing, to where it's really just because of you guys that we're now able to do like real surgeries in the field. And I mean, not only saving limbs and so, but I mean, there's a lot that you just completely, those people are not coming back if they can't get that high level of care that there's probably only a certain amount of countries that can really do in their military, Yeah.
And I'm sure Dr. Buzzelli could probably, attest to this too, but the Army and our FST training and support that we do, a lot of these other countries, our NATO and our, UN forces and everybody that we work with, they really model a lot of things after us as well. And so it's important for us to stay relevant, right? And I think one of the benefits of being in a trauma center with a civilian partnership, right, is that it allows us to have a foot in both worlds, right? Staying clinically, I think, relevant also within the research, right? Evidence-based practice, not only on the civilian side, but bringing that to the military and vice versa. There's a lot of sharing, a lot of data, a lot of research. And again, when I first came into the military, I was very shocked at how much was actually shared and how much the civilian trauma centers modeled after us. Whole blood administration is kind of an example of that, or how we apply tourniquets. It's quite fascinating, actually, that we get to operate in both worlds.
Oh, for sure. And when they go through the trauma training center, are there specific deployment locations that they automatically go to, or is it just, an open book, they're going wherever in the world, or do you guys have set, rotations? Yeah,
so the teams are typically coming to us in a pre-deployment fashion, as you were talking, right? That basically the events of September 11th kicked off a series of subsequent events that basically everything we have done has really been in more of a deployment type of training, whereas that wasn't its initial vision. But the locations that the teams go to, while there are some variability, I mean, it's essentially where we've been at war for the past 20 years, right? Teams were going to various places in Afghanistan, various places in Iraq, and occasionally some places in the rest of the world, typically in some locations in Africa.
Okay. I was going to ask you on that too, because Afghanistan being just recently kind of blown up with some news there, and actually having some casualties, not only of our own, but then many Afghans as well. How do your teams respond in like, say, that type of environment where it's chaos, but then, obviously you have to have medical staff in there as well, just to be able to get them out. I'm sure maybe some of them were able to provide support in that scenario too. Is that something that is obviously you guys train for, but in that element with just so much rapid chaos and change, were there also some like medical personnel there, or was it just like 11 Bravos and infantry and things of that nature?
What, at the end of Afghanistan, just a few months ago?
During the pullout, because just thinking of like thinking of how everything comes out, like we're probably infantry, we're probably the last ones out there. When do the medical staff kind of start packing their things up and leaving out of there? I mean, if that's something that's like a topic.
He's got a great story for you. He was there. He was probably one of the last ones running on the plane to get out of there, saving a life.
Shit.
Saving lives till the very last second.
So
I'm like talking out of my ass here, just like, all right, how do I word this?
It's like, funny you bring that up.
Yeah, interesting you mentioned that. Yeah, I was in.
No wonder why you just got back from vacation, man. It's like 2021 is different. Wow.
Yeah. So despite my position here at the training center, we are still deployable when the Army calls upon us to do so. And so I was in Afghanistan this past summer and
during the pullout.
Did not depart until 30 August. So I was there on the last day, left maybe about 12 hours before some of those last troops did. And so medical is there until almost the bitter end. Whereas at the very end, we have to then be evacuated prior to the very last troops going.
And did they that's crazy. First of all, did they send you out there specifically because it started to get, all right, here's some chaos going on. We need the best of the best. Colonel, we need you out there? Or were you already kind of out there just in case?
Well, I had a deployment that had been scheduled. It was kind of my turn to go. And so I was there with a forward surgical team, the 936th Forward Surgical Team, which is a reserve team, actually, that a lot of times in medical, they'll cross over and they sometimes use active duty docs on reserve teams. But I was there with them from earlier in the year. Got there a few months before everything really went sideways. The question you asked, though, is additional resources were brought in to expand our medical capability. So as the combat troops, with the addition of the Marines and the 82nd Airborne Division, kind of fighting soldiers increased, they also increased some of the medical that was there to support them. And so we had even another colleague, an orthopedic surgeon who works with us, that was brought in on a separate forward surgical team that joined us for about 10 days.
Oh, wow. And I'm sorry, I didn't mean to interrupt you. I was going to say, what's crazy about that is the teams that they deployed with recently trained with us in the States here in Miami. And so talk about, right, like full circle, instructor cadre is now part of their team. And that's something that we really stress is that, right, your paths can cross again at any time. And here, just because he's the director, right, doesn't mean that he's not able to deploy and still has that bedside skill, still able to use his skills as a trauma surgeon, not just instruct, but he could walk the walk and talk the talk, which I think is very unique.
Yeah, for sure. Because basically, I mean, you're going back to training trainees, saying, I just use these skills that I've been trying to train you guys, and that this is the reason why we take things serious and why, we do the things we do, which is, kind of like, almost feel like, is that like Michael Jordan coming out of retirement back to the Wizards, John? Those skills don't perish, man.
I'll say this: I feel very fortunate that I have had the experience that I've had the last several years at the Ryder Trauma Center. It is such a busy place, but really wonderful place in terms of the intensity of the trauma care that goes on there. That I truly felt prepared to take care of the people that we were dealing with overseas, particularly the Marines that were really severely injured during the suicide bombing attack.
Yeah, and I mean, I also read too, because obviously, it hits the news. I think it was 13 that ended up
13 that were killed. Yes,
that were killed. But I read a little deeper into that too, and I think I saw 90 in total, like civilians and everybody killed over there, and that's something too that I think kind of goes unnoticed, to where maybe you can lighten on this a little bit more too. But like, if you have 5 surgeons, if that amount of people are coming in, even say just the Marines, 13 come in for you guys to service. I mean, if you don't have the staff or the capabilities or the technology or the teams on there too, I mean, you guys are almost overwhelmed in and of itself, because you're not just talking, you can all operate on 1 or 2 people. All of a sudden you have 5 or 6 or 7 people come in. I mean, how do you handle some of those overwhelming scenarios, I guess?
I guess key is to have lived it, right? To train it day to day.
Yeah.
Like, and that's I think one of the highlights of our training program. If you try to rehearse medical scenarios in a notional way, they're very abbreviated. They're not nearly as intense.
They're not as authentic.
Yes,
really.
yeah. And so it's really essential to take care of real patients. And that's why I think our training program is so valuable and so successful, because it is some of the maybe few occasions that some of these forward surgical teams are going to work together as a complete team, taking care of truly injured people. It's not mannequins. It's not anything notional about it. It's the intensity is real, but the time is real. And that's, I think, maybe the point you're getting at, is just how time consuming some severely injured patients are. In terms of the medical care that we can render, it's possible, but it's very time consuming. It's very labor and resource intensive. And so you do,
to say the least, resource intensive. That's a perfect way to put it. But that's,
and so you do find that there are limits. And so when you have a really large casualty event like we had on 26 August, we were kind of at our breaking point in terms of number of patients we could take care of simultaneously, but you triage appropriately. And again, that's another important thing that we train and teach is making good triage decisions so that you take care of folks that are salvageable, and then you then just keep working and working. And we worked for about 18 hours straight that day, kind of nonstop, with multiple ORs going and people getting blood and resuscitation and care over a pretty intense period of time. But I think when you said some of the casualty numbers, I think we treated 60 or 70 additional patients that did survive. Some being other U.S. service members, some being Afghan civilians that were caught up in the incident, and I think the results were in some ways better than I expected. It really started out, we thought we were in a bad spot, but we were able to pull quite a few people through.
Yeah, I was going to say, because, I mean, if you're talking, I mean, 13 ended up passing, unfortunately, but, I mean, if you guys aren't out there, if there wasn't maybe a little bit of planning ahead on who was making those decisions, I mean, you're talking probably a lot worse on that. That's something too, I think, kind of goes unnoticed too, just where you guys are also helping not only, our own, Marines and military personnel out there, but also just random people that are caught up in that. Because is that something that's, you guys have like, I would say not a code to go by, but your procedures too on
like a medical rules of engagement.
To who gets treated first and and things like that.
We do have them, and each theater of operations is slightly different, and it's usually up to people, obviously, who are outrank us, who make those decisions.
Yeah.
But typically, it's pretty rare that you will see a military treatment, I think, role 1, 2, right, or 3 that really truly turn away a bunch of people. So what I think other people don't realize is we take care of our active duty, our veterans, our civilians, right, but also even local nationals, depending on the location that we are. And we're talking from the womb to the tomb, you know, of all ages, all backgrounds. And again, I think that's what makes us, I think, unique in that entity.
Yeah, now to go back on the authenticity that, you know, we were kind of talking about during the training, that is sometimes the only thing that's hard to, you know, make real, you know, because if somebody's going through a scenario, you want them to make it as real as possible so it feels live, so then they're more prepared to get in when they're actually there. And I was reviewing a video from your website, which there was a kind of like a scenario, I guess, a training scenario where somebody was in like a motorcycle accident or so, and then they're wheeled in, and like as I'm watching it, I see this guy on the bed who's just like covered in blood, and everyone's just like rushing to help him, and the camera's in there, and I'm like caught up in it. I'm like, how did they get the cameras in here while, you know, this
like,
guy's
this is
bleeding
crazy.
out there? Yeah. I was like, poor guy. He's just laying there, you know. He's like, you know, he doesn't know he's about to be on TV. But then at the end of the scenario, they said that, you know, it was an actor, and that people didn't realize, or the trainees didn't realize that it, you know, it could have been real, it could have been fake. And then even me, I was fooled on it too, and I could usually see right through that stuff. Usually it's just, you know, plain dummies, or the fake blood is so poorly done, but that was as real as it got. And then it wasn't until the end where I felt like the trainee, where I was like, oh wow, that was just that was fake, but it felt so real. And that was the first time I've seen something, because I've watched like police training videos too, and EMTs, and you know, that's the only thing that it usually doesn't have. But from watching that video, I mean, that seemed so real, because it was a real live person too that they were working on.
Right. And I think, you know, again, just kind of going back to how we train, we talked about like notional training with mannequins, right? And then you talk about when we are at Ryder Trauma Center, where else do you replicate war wounds? You have to come to an inner city where we're going to get those type of wounds. But you were correct. We trained them long hours. They're in a didactic phase for the first few days of the course. It's a 2-week course. And then they go into a clinical phase. And this is not a walk in the park. You know, this is something that like we really push that this is real, that any one of us can be there together, that it's important for us to assess their team dynamics, because that's the other piece of it, is not just the, oh, snap, like this is real, like that guy's bleeding, we need to do something about it. It's more, how are they working together as a team to solve the problems, or to resuscitate, right? How do they problem solve? How do they troubleshoot? And when they go through the course, they get a mix match of multiple things. So that is to keep that stress level a little bit high, to keep them at that peak performance. But yeah, that's interesting that you were also like, this guy, like.
Yeah, I was amazed. I was like feeling bad for him, because he doesn't know he's on TV. He's just gotten through his motorcycle accident. Yeah. And then I, you know, after I was like thinking to myself, oh, that must have stunk being that actor where you have like people trying to resuscitate you, and you don't need to be resuscitated because you're an actor. I was like, oh man.
Yeah.
The reality is, though, very quickly, then those aren't actors anymore. I mean, they are really taking care of patients that come to the Ryder Trauma Center.
Yeah.
I do want to make one point. You know, the Army teams that come are composed of, you know, board certified physicians, licensed nurses. You know, these aren't, I guess, trainees in the sense of they're still undergoing their medical,
like basic training wise, and
they
that's a good point.
are fully licensed and certified medical practitioners. It's just they don't necessarily practice trauma regularly, and they certainly aren't employees of Ryder Trauma Center. So they are brought in kind of a training, you know, I guess, mode or status, and they are integrated with the Ryder staff so that they can take full advantage of taking care of those severely injured trauma patients, but still with some oversight from the home institution.
Yeah, that makes sense. That makes sense. And who do they actually operate on, say, if there's a shooting in downtown Miami, they take them over there? Are they operating occasionally on like real-time folks as well?
Correct. But with someone like myself, who's a full-time cadre member here, or some of my other colleagues that aren't military but are the full-time, you know, trauma surgeon staff at University of Miami and Ryder, they would be the ones ultimately in charge, but they can integrate the Army surgeons and Army staff, just as if they would, other trainees that they have in their residency program and fellow.
Okay. Yeah, I almost don't want to use the word trainee to describe like
Yeah,
any
it's
of them
hard.
because like
Yeah.
they're that's probably a different word for that because of their status and knowledge because they've all gone to med school.
Correct. At least the
Okay.
physicians, because the forward surgical team, and maybe we didn't even take a step back and explain what that is, like who our trainees are, like what actually.
Yeah, I forgot to introduce myself, so
That's true.
no, we can do it later. We'll save it for
The art,
the end.
the art of editing.
We'll work backwards.
So, but an Army, I guess now that's called a forward resuscitative surgical team. The Army likes its acronyms and names, but it has surgeons that are both either trauma or general surgeon trained. They have orthopedic surgeons, so for fractures. They have emergency medicine physicians. They then have nurses of various types. They have emergency room nurses. They have ICU nurses. They have nurse anesthetists as the anesthesia component, and then they have medics and LPN level trained nurses, as well as typically a commander and a medical administrative person, and that kind of makes up this 20-person team that we call a forward resuscitative surgical team.
Okay. And how many people make up a team? You said it's like 20?
Typically 20.
Okay. And so basically you would consider that like a class?
Yeah, so when a course is in session at Ryder, it is usually typically one forward surgical team. So they typically bring all 20 of their members.
Okay. And then it's basically set that 20 then would then deploy to the same place on whatever the rotation is?
Sometimes they split. So sometimes you'll hear, oh, this team is splitting. And so in an ideal world, it would be nice to have all 20 of your personnel,
for sure.
In one location. But more frequently, you will see that they will actually split into 2 teams of 10 in 2 different locations, which now, broadens your level of care, your area of influence, right?
Yeah.
In that side. And then you even have teams which split off into what we call a ghost, which is your golden hour team, basically, where they will be able to actually go forward a little bit more with that element and take care of them surgically and then come back to that 10-man team. Again, another piece that makes us unique is that we are very good at doing more with less and being able to save lives. And if you think about that's 3 different echelons of care, right, out there in the same element from the same team. And that's also something else that we evaluate their teams coming through is how do they function as a team? Because we have some teams that come through that are fantastic clinically, but it's the first time they've ever worked together. So how do you bring that confidence and competence,
and
right?
personalities
and egos and attitudes, right? How do you bring that all together?
You're just putting together like an office, basically, to an extent, I guess.
Right. But I will say, based off of our reserve brothers and sisters, along with our active duty, like we work with some really amazing folks. And even though we are serving the same military and the same purpose, it is awesome to be able to train not with them, but train with them and for them, and be a part of that process. One thing that I really love about what I do at ATDC is that I came as a student in 2017 before I deployed. And I remember thinking, wow, like what a great program. And I can tell you firsthand that I was a better officer, a better nurse, and a better leader after coming through this course for my deployment. A lot of our young officers and are enlisted too that come through the course, or before they come to the course, think that they're the bee's knees, right? I was this big shot, at my previous duty station. And then you get to the trauma center and you're like, oh man, like this is real. Like, wow, like that leg's barely hanging on there. Like, I think I know what I'm supposed to do. Or I think I know how I'm supposed to lead my team who's looking to me, because I'm equally shocked, in the moment of what I'm looking at. And then you have those aha moments, right, where the Christmas lights come on and you're like, maybe I do need this training, and then it all comes together. But I can definitely say again that coming as a student now here as cadre, as an instructor, we've made so many changes to our course to stay relevant, like I talked about earlier. It's truly rewarding to see the things that we do and the type of medical personnel that we help produce to take care of our brothers and sisters downrange.
Yeah, especially you being there. as a student at one point too, you're able
Yeah.
to see it from like day one all the way to current, which could be just invaluable from like a leadership standpoint. They're looking down and saying, okay, how could we get this better? I mean, they could look to you and just be like, she's been here since day one. Now fast forward, what are some things that we could be doing better and kind of implement to make things more efficient or whatnot?
Yeah. Actually, Dr. Buzzelli brought up, or Colonel Buzzelli brought up, one of our colleagues, Major Boomsma, who also was one of our cadre currently and then deployed to Afghanistan as well. And he would say that I was literally doing stuff and I could hear Dr. Buzzelli in the background, like telling me like, you need to do this or think about these things, and that he felt fully prepared, for something that I think, right, nobody really anticipated at what level, you guys were going to experience in Afghanistan. But that makes me as an instructor, as cadre, feel good that we are doing the right things and we are putting the correct material out and assessing the correct things. A lot of work goes into it.
And talk about always needing to be ready. When you were over there, did you, because if you're an instructor also kind of helping the trainees here, when you got over there, were you kind of familiar with the people on your team that you were already working with? Because if, I'm thinking you necessarily didn't have like that 20-man team here like the trainees are training to do with. And then when you get over there, you're with probably other cadre and so that have been teaching other classes too. How did that kind of mesh and work itself out?
Yeah, so it is always one of the challenges we deal with in military medicine, whereas maybe at a civilian place, you kind of, have an established team that kind of always sticks together. Of course, there's always some staff turnover, but it's a lot slower and over longer periods of time. But the military does expect you to be able to kind of plug and play and integrate into these teams, efficiently and as quickly as possible. Now, these particular folks that I deployed with, the 936 FST, they had come through our training, so I had met them. At that time, I knew I was deploying, but I wasn't sure with whom, so I didn't know that they were the ones. But it was, I think it's always fortunate to have had some, personal interactions prior to just showing up in Afghanistan with each other. And so we had that back in the, I think, November of last year. Well, I guess I should say it'd be November of 2020 is when they came prior to their departure for deployment. So, but that is a challenge. And a lot of times the physicians in particular are looked at as just being interchangeable pieces, but we learned that, with personalities and things, that it really does help to get some team training under their belt, and you start working out those kinks. It's not always going to be perfect. There still might be, friction points and tempers and personality conflicts, but as long as you've initiated working through them, your team's a lot better off.
Yeah, I can only imagine, especially in like that type of environment too, where everything is already stressful, and then all of a sudden you have, maybe people thinking it should be done this way or that way, something that I don't think really gets the attention that it deserves in terms of being so important to, succeeding in something like that. Because it's just like a team, just like in basketball, football, where people just have to mesh. You could have the best talent or not, and if they mesh, then you're probably in a better, a better spirit with that. That's and 18 hours straight, that's you kind of need that. That's with the intensity there, yeah, for sure. That's it's amazing you're over there too. You just 10 days and then you're right back?
No. Our one colleague was there for 10 days. I was there for, I think I departed in June and got back in early September. So yeah, I was gone about 2.5, 3 months.
Okay. Yeah. And you must have been one of the last, last people out there.
It does highlight though some of the other things we deal with is when things are going well, and we want them to go well when we're deployed, right? We don't want folks to get hurt. And so you might find yourself in a situation where there really isn't much work to do. You're kind of deployed and asked to be there, and you have this training and abilities and skills, and then they really do atrophy. You kind of sit on your hands, for lack of a better word, on some deployments. And that's kind of what we were doing at the beginning. There really wasn't any real intensity to the conflict when I first arrived. And so The downside to that, though, is if that team isn't rehearsing regularly, isn't using their skills, it can escape you, and you're maybe not as sharp as you need to be. And so, again, kind of brings us back to what our training is always focused on, is that not only do we teach them for the 2 weeks they're here, but we try to give them some tools to say, you need to continue this. You can't allow yourself to be
almost on like a self-starter, when no one's watching too, to make sure you're still.
Well, we
you
help
got to
identify.
rehearse, and you got to keep your knowledge base up. You got to do these things that maybe you don't do all the time, because that one day comes along where you have a chance to save some lives and make some real impact. And if you're not ready,
And you got 60 people coming in that need your help, or they're going to die. I mean, geez.
and so while 60-75% of my time over there, that deployment involved doing almost no patient care. The part that did was extremely intense, extremely professionally rewarding, but also could be many pitfalls if we hadn't been as prepared as we were.
Yeah, you said you got there in June. Was there any sense that that things could eventually kind of escalate over there with tensions? Or, I mean, I guess it wasn't until probably the end of July, I want to say, where, things started hitting the news, and, the different cities started kind of having different leaderships kind of take over. Or did you go in when you first went over there? It was like, all right, this is my rotation for the next 3 to 6 months. And, after that, then I'll come back. Or did you go into there kind of having a sense of this could get intense?
No, I'd probably say the first, that we were, expecting to maybe be over there to be kind of a just in case, supporting the troops that were there, but not really expecting any significant conflict. But the situation certainly did deteriorate rapidly. I think a lot more rapidly than anyone expected. And it just seemed like every update we would get, or any time to watch the news, it was all over the public news that the conditions in the country were deteriorating a lot faster than we had ever anticipated.
Yeah, for sure. I mean, you're just at a drop of a hat, almost like a firefighter, I guess, right? To a point where you're just sitting there, you get a call and there's fire, and then you just gotta jump into like an 18-hour session
you could
too.
be at the shower, right? You're just running in your flip-flops, to the hospital to go do what you can.
And I know you had said it was 18 straight hours, but I always think sometimes where, all right, well, what about the people who were just getting off of work? And then boom, that happens. Then you're 18 hours, you haven't slept yet, and then you're, then you're 18 hours more. I've thought about that with 9/11 too, where the firefighters who were working that evening shift, they didn't even go to bed yet, and then they're working round the clock for days too, and something just specific to think about just from a different perspective is that, to where I'm sure you guys have your nightly and daily rotations, so then people can sleep, and and some are staying up, to where that hits right before you haven't gone to bed yet. You're over a day of just straight focus, adrenaline too, because that's something that's just so interesting. I'd love to get your guys' thoughts on too, is the controlling the adrenaline in that scenario while still maintaining your physical precision too, where you're in surgery and in that chaotic, intense environment, and you're needing to remain physically calm, I guess, to have that control over your own body. So you can make cuts and sew up and so forth. Do you guys do any training with that in terms of controlling your adrenaline? Because that's just a whole nother world of training, I guess.
Well, I mean, we do put I should say, there's a difference between our personal experience, right, from his MASCAL experiences on top of mine. But to kind of go for the first part, you're 100% correct as far as that adrenaline, but a lot of the colleagues probably, right, in that sense, I don't know if you experience this, but at least in my personal experience, you can't go to sleep. There is no rest. And if you are resting and not actively doing patient care, you're running to grab your colleague's food, like trying to tap out. Somebody is always doing something in those type of situations. If they're working those long shifts like that, it's because poop has hit the fan and all hands are on deck. And it's not until it's over and you take your deep breath that you're like, man, I'm exhausted.
You could say shit, by the way, if you want.
Oh yeah, like poop. But it's just one of those like, man, like you don't expect that. Hopefully you hydrated beforehand, but at least in my experience from when I was deployed, it was all hands on deck. Nobody's sleeping. And if they are sleeping, it's not a comfortable sleep. So you feel better being there with your colleagues and seeing what's going on. Now, as far as the training aspect, that is one thing we try to replicate, but you really can't. We've had several rotations with students where we've had mini MASCALs at Ryder Trauma Center, and we're working side by side, elbow to elbow with our civilian counterparts, to take care of these patients. So that's a little bit of a factor for our students, or I should say our rotators, to see. But we also put them through a mass casualty type exercise before they get to the hospital, and that's with some notional, training. But we definitely keep it very realistic because, again, we need to see who's going to not crack under pressure, but see where some of maybe their fail points are, see some of their highlights, who is performing well, like who can handle this. And you'd be surprised, some of the ones that you think aren't going to make it are the ones that step up and they are like, wow, okay, this person's going to be okay. And you have some that we think should be performing, and they just need to tweak a couple of things, in their practice, to say, hey, these are the places, this is the time to make your mistakes, right? This is the time to figure out where your fail-safes are before you deploy. So we try to implement some of that training for our rotators, but I don't know if you agree with this, but until you really are faced with it in real life, you can only do so much, right? To see really, truly where you are mentally, emotionally, and physically.
Yeah, that's why I brought up before why I like so much that scenario that you guys had with a live human, and the trainees did not know whether it was fake or real, because you hear about that all the time where a cop pulls out his gun too quick and it's a 2-second split decision, and that maybe that cop didn't have experience yet, or maybe they jumped the gun, or it was a good decision, and you just never know what you would do in that scenario until you're actually there. And I love the training that you guys do on that, because it seems like it is as live as humanly possible, to where you don't necessarily know if it's fake or real, and you have to treat it 100% as if that person could die right in front of you, because you don't know.
Right. And it's interesting that you focus or highlight on that piece when there are so many of these other big ticket items that we do during our training. And hopefully one day you can actually come and see some of the other things, to see what this forward surgical teams actually are capable of doing in about a room this size, a little bit bigger. And when we talk about, being in an austere environment, we're talking dirt floors, cloth tents, plastic tents, and the things that we can actually do out there. We replicate that for them.
Just being resourceful, I guess.
Correct.
Yeah.
And talk about like being a MacGyver, like we've jerry-rigged and done a lot of different things to just, again, take care of these patients. So hopefully you can join us sometime to see that piece of it, because again, that one piece of video clip that you saw is such a small portion of what we actually offer our teams. Yeah.
Oh, I absolutely would love that.
Yeah,
I would love to accept the invitation. Yeah.
You'd have to sign a non-disclosure form, but yeah, you couldn't talk about it on the podcast, but we could definitely. No. I think your mind would be blown to see what our teams are capable of mentally, emotionally, and physically, but also with their skills and the profession and like the courage, I want to say, that some of our individuals really display during this time. Yeah,
that mentality of just being so super focused for so long. Maybe even like being in the same posture for like, that amount of time too. I mean,
yeah, I think you were saying one of your colleagues was performing surgeries on the floor, right? Like they had just run out of operating tables to talk about, the drive to want to save lives. And I'm a different kind of warrior, but for me, if I was a war fighter, like if that doesn't motivate you to be like, man, our men and women who serve in the medical community really care about us. I don't know what else would motivate you, to want to go. Oh, for sure. That brings, a question up. What made you guys like want to
get into the field, to start, rather than just going into like more of like a private setting and so forth. I'm sure the Army treats you guys pretty well too, but in terms of a privacy or a private standpoint where, you can maybe run your own private practice, things of that nature, why choose the Army over, a ton of other opportunities that, you probably could have,
Yeah, that's a great question. Did you?
Yeah, I can. Just I think the professional reward of it. I mean, there's personally for myself, I had a desire to serve. I wasn't really sure, how I would fit into the military. I had some early thoughts of, maybe serving in other ways, but once it became clear that I was kind of on my way to becoming a doc and a surgeon, I thought for sure that was a way I could give back in a meaningful way that didn't necessarily cause me to become a war fighter myself. And so I guess that professional reward of taking care of someone who's really truly putting their lives on the line for our country, but then when you're deployed with them, in a sense, they're putting their lives on the line for you as well. Like they are there as part of your protection while you're overseas. And so it just, it bonds you in a way that you really value taking care of them. And it's not to say that you don't get professional reward from taking care of random citizens that get hurt here in the city of Miami, because you do. But there's just that little something extra about taking care of a soldier or a Marine or an airman that gets injured overseas. Of course, with the desire that you're going to make them better, get them back to their loved ones and their family, and that's really kind of for me at least, that pinnacle of what I can do professionally. And so I'm proud to do it, and that's why I got into this job and have stayed in this job. Yeah.
Because I mean, you've stayed. You're how many years?
So actually, in terms of length of time on active duty, not very long. I've passed the 10-year mark this summer, which in the grand scheme of things is not a very long Army career. Just because I had done all of my professional school and training on the civilian side, and so I didn't enter the Army until a little later in the pipeline.
Yeah, but it's quality over quantity there. You know what I'm saying?
Oh, 100%.
For sure. Yeah.
We'll keep them.
Yeah.
Yeah.
And what about you, Major?
Yeah. Well, I've been in for 13 years. Loved every minute of it. But I would say I come from a military family. So a lot of males on my dad's side have been combat arms, enlisted, and deployed multiple times. My dad, for example, was an armor NCO and retired as a sergeant major. And just growing up in a military family, seeing the sacrifice that happens. I actually have some close friends and other family members that have gone through all of the echelons of care during their deployments. And so for me, it was very important to serve. Like I said earlier, I'm a different kind of warrior. I am not the one to be running up a hill, throwing rocks and, doing all that stuff. Even though I am trained in a lot of soldiering skills, I feel that my skills are a lot better suited, providing that medical care. And so for me, it's more of a personal thing because I've had so many, loved ones that have served and continue to serve despite their injuries. So I wanted to be part of that of, hey, I'm okay being behind the fire, of the lines, to be able to take care of them so that they can go and fight.
And you're the first person people start yelling for too in those.
Either the medic, or the nurse, but usually it's doc. I think even doc has been used across multiple services for medics as well. But usually, I think we're a good team medically wise. Yeah.
What kind of plans do you guys have in the future? Anything like in the immediate, or you guys see yourself kind of still with the trauma training center still training some troops as they come in and out?
Well, that's a good question. One of the things too, we do a lot of our process improvement, right? Like within the program, again, to remain relevant. When we talk about our simulation cases that we do with our rotators, we take a lot of actually some of the experience that Dr. Buzzelli and Dr. Boomsma actually went through in Afghanistan to make sure that our patient simulation library is very relevant. We also wanted to, do a little bit more social media because I think a lot of people don't realize or know that what we do is actually a really big deal. And we've kind of been like a best kept secret here in Miami. And when people find out, like kind of your reaction when I first met you, you were like, I'm sorry, what do you do? And I'm like, I'm an Army nurse. Like, this is what I do.
I'm like, holy shit, you train people who like go right into like combat scenarios almost, and lifesavers right after they leave you, and you teach them. You're not only just one of them, like you also teach them.
Yeah, and 100%, right? I think again, what we do is you'll hear about other medical trainings, right? Not only within the military, but also on the civilian side, that they take their rotators or their students and they kind of drop them off in a clinical setting, and then they come and check on them, and we work elbow to elbow with them. And just kind of like Dr. Buzzelli talked about earlier, is he's able to be picked out of being a cadre, an instructor, and able to be put into a team and function clinically, just like the rest of our cadre are. And they're subject matter experts, or we call SMEs, in the military, in their job, that any one of us could be picked up and put on a team, and we are subject matter experts with our clinical practice guidelines. And so, again, I think a lot of people don't know or understand what it is that we do, but we're always looking to be better, always staying relevant, sharing our data and our research, with the civilian side, because we want to be able to influence that across the world. Because how cool would that be, to go to another country to be like, we wrote that policy. Like, I was a part of that, like, it's pretty neat.
I like it too. You guys are kind of like a hidden gem.
Yeah. Everybody wants us at a party, right? Because they know it's okay. Everyone's safe. Like, the Army team is here. Yeah.
Yeah. I can imagine too how delighted the troops are overseas when you guys come in and they know that they actually have surgeons on base with them. I mean, they're not just kind of by themselves with someone who might have 6 months of Army medical training, but you have like up to 20 people who have gone to medical school for this, and in case something happens, that might give them some more confidence too while they're out there, to know that if something does happen, that somebody does have their back physically, because it was probably a little tough if you're just out there with a medic who might just be able to resuscitate you, maybe stuff some gauze in your gunshot wound or revive you for a second, but to know that if something happens, you're in good care when you get back, probably it's got to go a long way.
Yeah, no, that I think that is cited fairly frequently, that's how those that are actually asked to do the real combat fighting, the more supported they feel, and certainly medical is a big part of that they know their job is inherently dangerous, that they are, by the nature of their job, accepting some inherent risks of bodily harm and maybe even death, but knowing that there's, some folks that are well-trained and hardworking that are right there behind them and ready to go if they need them, is, I think, a major motivator.
Yeah, because I feel like they're the Army and the military as a whole are starting to implement more training into just the soldiers coming out of basic training for a couple months, and they're trying to here's your job and your skill set and what you need to be trained in, but actually here's some medical on top of that too, because they're really trying to get that instilled into everybody, because it is just so valuable.
Yeah.
And just from like a mentality, knowing that you guys are behind them as they're going, it just got to give some more confidence.
And I think another like more funny, part of it is, I don't know, again, if you've experienced this, but in my last deployment, we were with an SF group, right, that was there. And it was so funny because some of us would be like, oh man, like we ran out of sunscreen. And the next day there would be like a case of sunscreen from our special forces operators, and I was like, this is like Santa, like this is so great. They get the best care packages too, and next thing you know, like they're sharing their snacks with us, and those can be those small little morale boosters. So I 100% agree that usually your supply, your food, right, and your medical usually get treated the best when you are out there supporting the troops. So I can't complain.
They're smart then.
Yeah, they're treated pretty good. Yeah.
Yeah,
I don't know if you.
I agree though that I think the higher
prime rib.
Yeah, the higher risk the job. So like when you do start working with some of the SF communities, that they maybe more so than the average soldier recognize the value of having a medical team there to back them up.
Yeah, because I can assume, especially on that level too, where they've probably been almost in life-threatening scenarios too, where they come back with a gunshot wound. They know their life is just solely in your hands. I mean, they probably really, really know the value in you guys, rather than maybe somebody who just came out of basic training, hasn't deployed yet, and is just used to having medical staff around them at all times, rather than being in that live scenario where, I mean, at the end of the day, if something happens, you guys are it.
And the SF community too have, excellent trained medics, and they're called 18 Deltas. And these are their special forces medics who, do some incredible things, and their scope of practice is just insane.
And their training too, where it's in combat scenario.
Correct.
Right?
And so it's always nice that we do joint training. We share toys, right? Like, oh, you got ultrasound on your phone. Like, how cool is that? And sharing some tips and tricks, sharing of supply. And so again, when we talk about that brother sisterhood, like that is a legit real thing, especially as our brothers and sisters are getting hurt. Like, you all of a sudden become one for one main effort. And I don't think there's anything like that. Even on the civilian side, like, yes, we come together at times, but the camaraderie within, I think, the military and especially the medical community is very special.
Yeah, because if they spend maybe 3-6 months with you guys too, you guys have legit medical degrees, they could walk away with a whole nother field, learning it in those scenarios too.
Yeah, and sometimes it's longer than that. When the war first kicked off, we had like 18-month deployments, and you're talking like that's like enough time to bond as a family, And when they leave and somebody gets replaced, you're like, who's this new guy? Like, you got big shoes to fill.
Yeah. I know it'd be nice to have everybody on the same like rotation there, but no, that's where were you deployed?
I was in Iraq.
Okay.
Yeah.
Yeah, it's I feel like it's still ongoing too. It's not just, everyone sees the Afghanistan pullout and everyone's like, okay, now we're out, we're done. No more combat, no more troops at risk, and it's like,
no, we're all over the world.
No, yeah, and even I feel like still over there now, it's still gonna, we're still gonna have some. Even just like 2 days ago, I think that there was some threats because of it was the anniversary of Soleimani's death.
So it was.
A year or two ago too. So it's just like it always a threat. And then you've got now, with Afghanistan, kind of back in different hands to where, I feel like there's some on edge on that, but you can only time will tell, I guess, right?
Yeah, and until I think there is truly world peace, I think the Army and all of our military, I think entities, especially the medical folks, will continue to train because our sole goal, right, is to take care of our brothers and sisters downrange, wherever that may be, land, air, or sea, right?
Yep.
So our program will, I think, forever be relevant and needed. We have several other courses, right, that are very similar, that are starting to build up, which I think is fantastic. The ATTC, cadre, love what we do, but you can only train 11 teams a year. And I think something that we need to have is more training, and more sites and more partnerships can actually blossom to the type of relationship we have with Ryder Trauma Center here in Miami. Could you imagine like every other year going to a different course and being able to get in? We only have so many seats, and to talk, not to like toot our own horn to be like, look how awesome we are, but like we are truly booked.
No, but look how awesome we are.
Look how awesome we are. Yeah, like we are booked
Standing
out
room
from
only.
till 2023, and we just started the year. If you think about it, and then we have teams always wanting to come here, and so again, as cadre and as a past student of the program, you want to make room for everybody, but there is just only so much we can do for so many teams. But we do the best that we can. So I'm hoping, again, that the military continues to push those programs, because we truly need that continuity from, I think, the civilian side.
Do you think, another incentive for people to, come through the school is it's in Miami, and if you're in the Army, it's like, oh, I'm stationed in, Texas, dirty Texas, or like, Sandy, Arizona, or cold Alaska, and then Miami.
There could be worse places to be assigned, right?
Yeah, a lot of, military senior leadership, when you're like, I want to go to this course, and they're like, where is it? It's in Miami. Like, Miami. But again, where do you replicate war wounds? You've got to go to this inner city, and unfortunately, Miami is keeping us in business. As much as, I think some, locals probably don't want to hear that, but it is very true. Just like there are multiple other inner cities too that also provide, I think, some of the civilian partnerships that they're starting now to offer that same training value.
Yeah, because that was one thing that surprised me when we first we're talking about the Army Trauma Training Center being in Miami. I was like, there's one in Miami. I was like, are they crazy? They're going to have like,
yeah, it's just down the block. Don't you hear the ambulances every night?
Yeah. I was like, people are coming right down here right before they deploy to Miami, you know? I was like, oh, but that's good.
He knows the gunshots, right?
Do you know why they chose Miami as the venue, or?
The specific details, no. I mean, that's something from 20 years ago, but in general terms, I think I have a very clear understanding of it's the type of trauma that you see here. So across the U.S., there are, I would say, many very busy level one being the highest level trauma centers. But there's only certain cities that have really still very high rates of penetrating injuries, that being gunshot wounds and stab wounds, which are going to be more similar to what we see in the military. And so Miami, for better or worse, is one of those cities that still has quite a high rate of penetrating trauma injuries. So the desire to be here, the need to be here, really matches what the Army is looking for.
What is in your perspective, and I'm sure there's stats on this too, what is, would you say, the worst, obviously, this is broad terms, but like, say the worst wound to get, is it like getting hit in the extremities? Is it, an IED? Is it a gunshot wound? What would you say is the biggest fatality wound that you see most often?
So in the military, it'd be described as a complex blast injury. And so that's similar to what we were seeing in Afghanistan at the end of August. So where there's an explosion and there's fragments and basically the possibility of getting injured all over in many regions of the body, right? You can have head and neck, you can have chest, you can have abdomen, you can have extremity injuries. And so it just, there's so many things going wrong all at once that becomes very difficult.
You got to be sewn up like 100 different ways.
Yeah. And so sometimes an isolated gunshot wound, although it can be devastating, can also be, very treatable as well. That's one thing that this current war, I think, has reinvigorated, is the use of tourniquets. So for an extremity injury that you can place a tourniquet on and stop the bleeding, that patient is very likely going to do well, because that tourniquet can stay up for even up to several hours until that person gets to an appropriate medical care to treat that wound. But where we kind of still earn our keep as surgeons, or it's those areas where you can't compress it with a tourniquet. So anything kind of in the neck, chest, abdomen, pelvis is all kind of our territory to stop the bleeding, because there's no tourniquet for those areas of the body.
Yeah, I guess there's no
neck
guide,
tourniquet.
right?
Nope.
Yeah. There's no neck tourniquet. There's they probably just leave it up to you to make your own, decision on what to do, kind of, I guess.
Well, I mean, there are, well thought out ways of treating those patients. And so another big advance that's occurred throughout the last 20 years is getting back to the use of blood as what we resuscitate patients with, and not just crystalloid or fluid, and now really even whole blood. If you're familiar with anything in medicine, blood typically these days is divided into its different components. You just get the red cells, or you just get the platelets, or you just get the plasma. But we've gone back to using whole blood, because obviously if you're bleeding, you're losing all of those components of blood. And so in the initial phase of trauma, it's become much more advantageous to replace that with whole blood. And so that has kind of won its way back into favor from this experience. And it's something that has crossed over from the military experience into the civilian world.
Okay.
And just to put it in perspective, when you have a patient that needs quick, resuscitation or massive resuscitation, right? In the past, with the component therapy, you could be giving anywhere from 40 to 50 products, right? And so you're thinking those are individual bags. Mm-hmm. That takes time, right? You've got to check it, you've got to spike it, you've got to prime the tubing, you've got it, right? And you're talking about multiple bags, and that's really a dedicated job. Versus using whole blood, we went from 40 to 50 components to maybe 10, maybe 15 bags of whole blood, right? So when you talk about efficiency, but also the outcome of the patient, that makes a huge difference. And also in the work productivity, as you go through. And I remember the first time I had used whole blood as a nurse, I was like, this thing's a miracle drug. When really it's just, like he said, you're losing the whole component, right? All of the components of the blood out. Why not replace it with the same thing? So it is definitely very, very cool to see in real life. Wish we could take you on a clinical rotation. Hopefully you wouldn't pass out. I think you would be shocked. Like, wow, you guys do this every day?
Oh man, I would not forget. I would love that. I would be like a pig in shit just seeing you guys in action, you know. I'd be like, oh, this is so super cool. Is this real or is this not real? How do I?
Yeah. You're like, we got you.
Yeah. Because it's just amazing stuff. You're like basically like in an ER, but like you're
a
operating
dedicated
on,
trauma center. Yeah.
I did want to add, though, you had asked about like how we ended up at Miami. I really do think it's important for me to say, publicly on this podcast that I guess the vision and the willingness of our partners, and so it's actually several different entities. It's the wonderful medical center that's here is really made up of several different things, and so the military is actually partnered with kind of all of them, and so it's the University of Miami's School of Medicine. And within that, there's a special entity called the Michael Gordon Center that is a dedicated center for simulation and medical training. And so we utilize it, but it's also utilized by the medical school and particularly a lot of Miami-Dade fire and EMS folks as well, that this way of simulating patient care is a great way to kind of, if you talk of training in kind of a crawl, a walk, and a run phase, to get you on either that crawl or that walk before we're over at the Ryder Trauma Center, running a marathon. So, but that's the first entity, and they, again, like all of these folks are just tremendous partners. Their willingness, because these relationships can break down. I mean, there is a history of other things similar to this that just haven't worked out for various reasons, and so. The leadership within our civilian organizations is really strong and committed to the Army. The others are, of course, the Jackson Health System, because they are the ones that own the Ryder Trauma Center. And the last is the Miami-Dade Public Health Trust, which is this really wonderful thing that Miami-Dade has that years ago the citizens agreed to have this trust fund established to pay for care for those who couldn't afford medical care themselves. And so all three of those entities are signing these agreements to partner with the Army over the years. And so it really has taken all three of those elements. Again, as cool as it is to talk about the Army, these folks are, they are really the ones.
Yeah, because they're providing the space and
they're like dedication and patriotism. And like when you see their support, and we have several of the staff, right, on the doctors and nurses side, and down to your social workers. We've got individuals who were prior service who had served, who have family members who are currently serving, and so for them to give back in this way and also to be so dedicated to us. And when we say like these are our family, we do our holiday parties together. We get invited to kids' birthdays and things along the lines of that to just show that like they've truly embraced us as family and in that medical community. And then they get to know the rotators, and we have some rotators that come through multiple times, like 5 or 6 times, and our civilian counterparts are like, hey, like how was it, how are the kids? And like it's really cool to see that they think they're doing a small part, but really it is a huge part in the grand scheme of what our program does. And at least for me, I'm thoroughly grateful, for that opportunity and to be able to train side by side with them.
That's good to hear, especially knowing, we're over 20 years in on that, right?
Mm-hmm.
And that lasted longer than the Afghanistan war and the war on terror almost, which is hard to do. You're talking 20 years on that. And I'm sure you guys know that better than I do. How long that is. What are do you guys have any goals for the trauma center in the next couple of years down the line? Is it to expand it all, or just kind of maybe get this type of training center in different locations or so? Yeah.
So the Army's overall plan is to develop more of these military-civilian partnerships at other big level 1 trauma centers, and so we'll always think that Miami is the best.
We're the OG.
Obviously, yeah.
I kind of like to say it is, you can always, they're almost like sports comparisons, who's the best at whatever, sport that these level 1 trauma centers, especially the bigger inner city ones, you can always compete to say who's the busiest, who's the baddest, who does the most, who does,
We
the
do
hardest.
have the best swag, though. I will say we have the best swag.
Well, the colors, the Miami
Yeah,
colors.
there you go.
I look at it as there's almost like this Ivy League of places that are still really very busy. And so they're all excellent. There are several excellent places throughout the U.S. That are providing some very high level, high intensity trauma care. And so the Army is trying to partner with some of these other locations that fit that bill and fit that need. And so that should expand our ability to train, because I guess you'd ask about like future desires or goals. It's really not to lose the lessons learned that we've kind of so hard won over the last 20 years. You don't want that experience to dwindle, and it will, if you don't create a system that keeps teaching, those that are coming new into the military, how to deal with these situations and how best to practice. And so we do have a number of entities set up within the military. So it's not unique to the Army. It's joint across the entire Department of Defense. There's a joint trauma system, which is now been in existence for quite a few years, but is now formally tasked with that goal of preserving all of our lessons learned and continuing to teach in a way that keeps us prepared, so that if we do find ourselves in a time of peace, that we don't completely let these lessons go. They codify a lot of things, what we call our clinical practice guidelines. So there's, no real way to do medicine out of a cookbook, but there are definitely guidelines that can help you, that can help you. And especially when it's stuff that you don't see a lot or practice regularly, these clinical practice guidelines can really give you a great foundation as to how to take care of a patient with a particular problem that CPG addresses.
Yeah, which is nice actually to have the CPGs, because you talk about gunshot wounds, blast injuries, burns, and then you get somebody with a snake bite and you're like, like, let me, what do we use for this again? Yeah. And so you have some of these other, things that people don't think about, right? Like, is still considered trauma, right? Any type of injury to the skin, you break the skin, it's trauma, So to think about like a snake bite, that does not make your top 10 sexy, trauma injuries. But that is something that, based on the areas that we are deployed to, a big thing that people should be like, hey, you don't need to memorize all of these CPGs, but at least you know where to get them, how to utilize them. But everything is to discretion based off of the medical professional that is there making those decisions.
Yeah, for sure. I mean, if I'm in, Afghanistan, or especially, some more remote parts of Africa, I'd almost rather get shot than get bit by some of those freaking snakes.
I agree.
Black mamba.
Yeah, no, I agree. But there's a CPG for that. So.
Yep.
Yeah.
Well, and thanks for coming on, guys. Before we finish, I just, I when you were discussing Afghanistan before, this popped up into my mind when we started talking about trauma too. Because a lot of times, there's obviously trauma with combat vets and, people who are in explosions and having friends die in combat, unfortunately. But, from your standpoint, to just, you're just kind of doing your day-to-day tasks over there, and then all of a sudden you get overwhelmed with such, horrible scenes of just people coming in. It's just, you don't know how many are going to keep filtering in that need your life-saving skills. Do you guys ever, experience some sort of that trauma too, as well, to where it's all over, everything's said and done with, and then maybe you think, oh, if I would have just done this, that, or the other, or if maybe I had this set up earlier in time? Do you guys ever feel like that as well? Because I feel like a lot of times that PTSD attention is always more so on the people in those exact combat scenarios, but maybe not as much coming from the table, I guess.
Yeah, I mean, Dr. Buzzelli Colonel Buzzelli actually talks about some of this with one of your favorite book recommendations, as far as taking care of patients. But I'll let him speak to this piece, since his has been a little bit more recent. But you're 100% correct that it's cool to talk about, but at the end of the day, there's only so much I think the human being itself can actually take. So do we have some medical personnel that probably I don't want to say suffer, but experience some of those feelings? Absolutely. Yeah,
because I feel like it's almost like you gotta put that, that almost like that immediate trauma, almost like to the back of your head for at least until you kind of get through it.
Yeah.
Yeah, I mean, the simple answer is yes. It's a little, I guess, different type of injury to you. Your to you personally. The I guess the easiest way to describe it is you don't ever forget the ones you lost. Those maybe haunt isn't the right word, but they're always there as a reminder to do better, to push you to keep going. I guess you talked earlier about like how you can push yourself through like 18 hours of surgery, and as hard as it is, you just realize what the outcome could be if you don't continue to push yourself. You don't want that the loss of that person's life to come back to make you think that you didn't do enough. You don't want that burden. So the ones that get away from you and do pass away from their injuries are very difficult. But they are, like I said, they're kind of that motivating factor to keep going. The ones that maybe survive and who almost maybe shouldn't have, that's like hitting the lottery. So it's this very extremes of emotional highs and lows of you get to tell that story of someone that like we said lost their heartbeat, so effectively were dead. You crack their chest, sitting on the floor on your knees. You get them to the operating room, you get them back, and a few weeks later you hear about them reuniting with their wife and their child, and that's like a feeling you just can't describe. It's like a lotto jackpot type of feeling. And so I guess it's really those extremes that we have to deal with on the medical side. I certainly would never compare myself or my experience to what actual folks have dealt with in terms of being in true combat roles where they are asked to or forced to pull the trigger and actually take another life. We certainly don't live that life, but it's a little bit different for us. The book that Sonya was referring to that I make mention of is called Rule Number 2, and it's a quote from the original MASH movie. It's rule number 1 is soldiers die in war, and rule number 2 is surgeons can't prevent rule number 1. And it's a great book. It's a short read. It was written by a Navy psychologist who was in Iraq at the height of I think 2004. So very, very intense combat operations. I believe she was outside of Fallujah, so a lot of injured Marines coming in every day, and just the book describes that psychological toll that the medical side of the military does deal with in taking care of these injuries. You just constantly see the carnage, the worst of the conflict, because everyone that's injured or killed typically comes through some medical facility, and they're kind of our cross or our burden to bear. But it's something I think most of us do proudly, and realizing that it's a trade-off of serving in the military without necessarily being in a combat arms unit that might even more seriously put your own life at risk.
Yeah, and to kind of end on such a humble note too. I mean,
know. I was like, maybe we should have talked about this earlier.
No. It just I feel like it it just heightens like the importance of like what you guys do, and really what like the Trauma Training Center does, because like I always look at it from a standpoint, if you guys aren't doing what you're doing, the domino effect that has, because then if you're not passing down that knowledge, then when people get over there, it's just tourniquets and simple
Wild West medicine.
Yes. I was going to bring up something from the Civil War where it's just it's very simple, because you don't have that, and you guys having the skill set that you do, and then choosing rather not to go into the private sector, but to be in the Army and to keep having at it, and then also just to deploy when you're asked to in those scenarios is I'm just like not even intelligent enough to describe it, I guess to say, because it, the whole military and army and, from combat arms and, medical personnel with you guys too is all just so important, and why it all works as just like a team, because I feel like you guys over there too in Afghanistan or in Iraq, there's no doctors over there except for you guys in that whole entire country with the knowledge that you guys do. I'm sure, because Iraq and Afghanistan, I'm sure they have their own little, medical hospitals and so, but you guys are on a whole another level.
And we do actually a lot of training with local nationals too, especially when I was there in Iraq at the time. And I didn't know this, and this isn't to say every doctor that is from Iraq or was there is not trained. However, the one that was actually present was a biology major and just kind of got tagged with the job. And he was like, I watch YouTube videos on how to do things. And being a nurse as a profession there is not recognized the way that it is here in the U.S. And, we can suture, we can clean wounds, we can pack wounds, we can give medications, we can help, suggest orders or write orders, if the doctor isn't available, versus in some of these other countries that do not value, I think, right, what the military, but also what U.S. medicine really can and is capable of being a force multiplier, right? Why would the doctor need to do these 10 things when the three of us are capable? He can go do something that is outside of our scope, right?
Rather than put like a tourniquet on or something like that.
Right. But we do a lot of that training, with them as well. So you're correct in the sense of, thank you for the compliment of like, we've got this top tier, you know what I mean? Like, I agree. I am biased though, so. Yeah. That we have this top tier, medical training and knowledge.
Yeah, but I mean, that is, I guess, one of the ultimate kind of big picture goals is to deploy a, well-oiled trauma system, right? Like we don't want just a couple of random, trauma docs and trauma nurses out there. It really needs to be a system of care that gets someone from the point of injury through maybe that first surgical team, that first forward surgical team that sees them, through then the higher levels of care that as we evacuate patients out, really do help them to survive with increasing that capacity and capability at each level that they go through. But that really is kind of the ultimate goal of this deployed trauma system that's similar or as close to what we can have in the U.S. as possible. And you're absolutely right. Some of the countries that we are deployed to have essentially zero medical infrastructure prior to our arrival. And that does make it more difficult because there's no reliance or capability of leaning on that.
That's a good word you use too, like infrastructure, because it really is. It's not just, people doing what they, are trained to do. I mean, it is a full-on system.
Well, and something that we have too in the U.S., right, is, oh, great, like we've done this trauma care and now there's rehab and there's all of these other services, right? Like the follow-up care. And sometimes we kind of get stuck in that position where with some of the local nationals too, where you are happy to take care of them, but then you're like, oh shoot, like, well now what? Like what's their follow-up care? Do we need to, you know what I mean? Like how is this going to work out? Or should we have not done this knowing, right, that there was no follow-up care? Which is again like kind of a transition, right, of thinking of again what we're used to in the United States, and then you go to an austere environment and provide the care, which is something actually some of my buddies now who are taking care of some of the Afghani refugees in the United States at these military posts were like, we have people coming up to us saying, I was getting cancer treatment like chemo back in the city. Are you guys gonna now do it for me here at a military facility? Good question. Let me find out, and so there's definitely some challenges that come with that.
Yeah. I would so love to even to pick your brain on that element too, on just, the refugees coming into the United States and the types of care that they get and everything behind that too. I feel like I'd probably keep you guys hostage for a whole day with that conversation.
No, we both got contacts of people. I mean, that there's such an array of stuff. I mean, shoot, you could do a whole segment on JTS conference, on itself, just what that is and what we do. But yeah, if you ever need any, other military, topics or medical topics, please come reach out, because we definitely have a huge community of folks out there that have these really important jobs and missions. It's not just us, right? It's in a bigger picture, well-oiled machine, I would like to say.
Yeah, I like that word too. And I will definitely probably take you up on that invitation to see what you guys do live, because that's like doing a ride along with a police officer. You think and then it's all, and then it's like, whoa, wait a second, this is real. Yeah. I'm definitely excited, and that's definitely excited too to touch base down the road too, and just kind of see where you guys are at, see how the the program is probably like grown and everything too, and best of luck to you guys too, especially if you guys end up getting deployed again and whatnot. I can speak on probably behalf on everybody listening that everybody loves everything that you guys do and is so appreciative.
Thank you.
It just can't be said any less than that, because it's it's indescribable. I mean, you guys have the knowledge, you're saving lives, and that's what I love to kind of promote on this podcast too. So Major Vargo and Colonel Buzzelli, thank you so much for your time today.
Yeah, thank you for
Daniel,
having
our
us.
pleasure.
This was awesome. This was really
Yeah.
cool.
A lot of fun.
Thanks, guys, and enjoy the Miami weather. I feel like everyone, all of our friends in the Northeast right now are like, they're packed in on a snow day or something right now, but it's like 65 and sunny down here. So
Yeah,
we're
nothing like
good.
drinking a PSL at 85 degrees.
Yeah. Well, thanks, guys.
Yeah, thank you. Bye.
With every star